Ladies and gentlemen, we now resume our symposium with our fifth and final discussion segment titled Next Steps, a focus on broadband and health data and social determinants of health. This segment will be moderated by Dr. David Ahern with the FCC's Connect Fall Task Force. Dr. Ahern, please proceed.
Thank you, Ben, and welcome panelists. This is the final panel of our symposium. Last but certainly not least, indeed, we see this panel as a natural bookend to the symposium, a series of mini presentations by our panelists who have been involved in research of one form or another, addressing broadband connectivity as it pertains to health. And so I'm going to proceed. So this is the roster of speakers that we have for our panel. Jill, Robin, if you could go ahead.
Thank you, David, and good afternoon. It's such a pleasure to be speaking with you all today. As noted, my name is Robin Gilbert, and I am the president of Fair Health. And to help frame this panel's discussion, I wanted to share a few slides that will offer some insights into this current status of telehealth utilization across the country, but also serve as a backdrop to the overarching discussion we've been having about broadband access. Next slide, please. For those less familiar with Fair Health, we are a national, independent, nonprofit organization established to bring fairness and transparency to health insurance information. We now have over 36 billion private insurance claims from 2002 to the present. It's the largest private claims collection in the country, and we receive over 2 billion new claims each year. Next slide, please. Fair Health has over 165 million telehealth claims from just the past 2 years alone. And these services are specified on the claims data in various ways. There would be 02 in the place of service field on a claim, which would indicate a telehealth visit. There are also procedure code modifiers that can also be used to indicate that a telehealth service has been performed and can be billed with any relevant procedure code. And finally, there are also specific procedure codes that would flag whether a telehealth service has been rendered, such as a 5 to 10 minute telephone consultation visit. Next slide, please. These two charts show how telehealth usage as a percentage of all medical claim lines has evolved over 2020 and 2021. As you can see, telehealth claim lines were relatively low in early 2020 prior to the onset of the pandemic. In March, as the pandemic began to take hold, telehealth claim lines increased to 8.1% of all medical claim lines and continued to increase in April. However, as the COVID-19 restrictions expired later in the year, telehealth utilization declined, and by September 2020, telehealth only accounted for 4.3% of all medical claim lines. We see telehealth utilization rise again in October 2020 through January 2021, which was likely a result of the growing number of COVID-19 cases in the US during this time. And in the spring and summer of 2021, telehealth claim lines dropped again as the country began to get vaccinated. In the fall and winter of 2021, however, telehealth utilization began to rise once again, likely a result of individuals taking precautions and avoiding indoor spaces to protect against the Delta and Omicron variants. Next slide, please. Here we're reviewing the top 5 telehealth diagnoses in 2021. As you can see, mental health conditions are at the top of the list, constituting 57.2% of all telehealth claim lines. Mental health conditions also dominated the list in 2020. Next slide, please. As mentioned earlier, there are specific codes billed on claims by providers to identify telehealth services. These codes can also identify if the telehealth service is conducted via audio only or over video. On January 21st, 2022, 3 modifiers were introduced to help us discern between audio only and video communication with the patient. Modifiers 93 and FQ both indicate that the service was provided to the patient via audio-only communications, and modifier FR specifies that the service was conducted via a 2-way audio-video communication technology. Next slide, please. If we look a bit deeper at the types of telehealth services, We can see here that in 2019, prior to the pandemic, telehealth services were more specifically characterized as either audio or video when billed. In 2019, 40.3% of all services were defined as audio only, and 21.8% were billed as video procedures. Only 37.9% of the services were not specified. During the pandemic, though, as more and more providers began conducting telehealth services, we saw the specificity of the billing decrease. By 2021, less than 10% of all telehealth claims were designated as either audio only or video. As telehealth utilization increased during the pandemic, providers who did not previously conduct telehealth services continued to bill their normal service codes, such as psychotherapy or evaluation and management services. While they indicated they were telehealth visits, they did not include a video or an audio specification. Next slide, please. Here we see that video telehealth services were more frequently used in urban locations than in rural locations throughout the year. In January 2021, video telehealth services accounted for 14.4% of urban areas, while they were only 2.7% in rural areas. However, by June and July, telehealth jumped by video to 13.9% and 14.7% in rural areas, respectively. With the new modifiers that became effective in January, we will now be in a much better position to evaluate both broadband access as well as demographic factors or other differences between rural and urban video telehealth use. Next slide, please. As you can see here, audio-only telehealth utilization was higher in rural areas than in urban areas. This chart also reveals that audio-only telehealth was more commonly used than video telehealth, no matter the location. Next slide, please. And finally, turning our attention to age and gender distributions of video and audio-only telehealth utilization. In 2020 and 21, we found that telehealth usage was generally more prevalent among females than males. Females of all ages sought both video and audio-only telehealth services much more frequently than males, with the exception of 0 to 18-year-olds, who showed a very small delta between male and female distribution. The disparity between female and male telehealth utilization is greater when looking at video telehealth services. Although the difference in utilization is less acute for those aged 65 and older, females still accounted for a greater percentage of video telehealth services. Audio-only telehealth services among this age group, they're more evenly distributed, with females and males making up 53.1% and 46.9% of audio-only telehealth services, respectively. Among the 51 to 64-year-old age group, the difference between female and male utilization of video telehealth services was 41.6 percentage points, while the difference in utilization for audio-only telehealth services was only 12.6 percentage points. With that, I'm happy to pass the baton to the next panelist and look forward to the discussion later on. Thank you.
Thank you, Robin. That's an impressive data set, to be sure, and really helpful to have that information shared with us today. We're now going to turn to Kirsten Frobaum. If you could introduce yourself and then your presentation.
Hi, everyone. Thank you for having me. I'm Kirsten Frobaum. I'm a senior evidence analyst with County Health Rankings and Roadmaps. So for those of you not familiar, County Health Rankings is a resource which uses data and other tools to illustrate how counties are faring across the U.S. with the understanding that our health is shaped by the conditions in our communities across a range of factors, from our opportunities for education to our ability to access jobs that pay a living wage and so on. Broadband access is one of our newest data measures, and for that we use data from the American Community Survey to report the percentage of households in a county that have access to broadband. And then you'll see from this slide that access is not the complete picture. Policies and programs that affect access, affordability, and adoption of broadband, with the end goal being that individuals can meaningfully use it, also are really important. And so in addition to data, County Health Rankings has a database called What Works for Health, in which we review the evidence, including for broadband expansion, to suggest what's working well to communities. Next slide, please. So broadband research, to give you some background, is often looked at from two different angles. So we know that when communities have access to reliable and affordable broadband, there are significant benefits. And we know that when communities lack this access, there are significant harms and barriers to opportunities. So with regard to benefits, what the data and the evidence illustrate is that access to broadband, especially at higher speeds, such as 100 megabytes per second, and in rural places that have traditionally lacked broadband, can really increase communities' employment rates. We also know that broadband is associated with greater access to healthcare via telemedicine, and that it improves economic stability because people can do things like telework, search for jobs, and file for unemployment. Further, food security is improved. People can get groceries online. I'm sure some of us experienced that recently. Check food pantry hours, and importantly, enroll in state and federal programs like SNAP. And then people can continue their educations, as well as accessing the social support that's been so important for our health, especially for older adults and for all of us during the COVID-19 pandemic. Next slide, please. So conversely, and this is why broadband is considered not just a social determinant of health, but a super determinant of health, there's evidence to show that when communities lack broadband, individuals fare worse economically, educationally, in terms of the social isolation and their access to clinical healthcare. And all of these shape our overall health outcomes and how long and how well we live. So it's also important to point out here that access, affordability, and adoption of broadband are all challenged by systemic and historic barriers to broadband expansion in both rural and urban communities with lower incomes. So government authorized redlining practices from 100 years ago are still informing our health today. Neighborhoods that were once graded by the Homeowners Loan Corporation as undesirable for reasons to do with race and income continue to experience disinvestment. And as you can see in the graphic, historically redlined neighborhoods have fewer individuals that own homes, more families who live in poverty and have lower education attainment, and more than 1 in 4 homes in these neighborhoods also lack broadband. So the data increasingly show that income, as much as infrastructure for broadband, is an important barrier to access. So this is illustrated by the fact that in both urban and rural areas, households with the lowest incomes are the most likely to be without broadband. For example, in the most urban areas of the US, 44% of households that earn lower than $20,000 a year have no internet. And in the most rural areas, 56% of these low-income households have no internet. This is significantly below the national averages. What this data shows is that there's a cycle of disinvestment created by policies rooted in racism and inequality. And this is why the initiatives today, which focus on expansion from this equity perspective, considering not only expanding infrastructure, but also ensuring that broadband is affordable and that digital inclusion is happening. So things like tech and learning support in communities and getting people affordable devices is what's needed to ensure that everyone can access the benefits that I mentioned. And if you want to go to my last slide. Perfect. So this leads me to where you can find our work and more on this. So on countyhealthrankings.org, you can find the data measure I mentioned on broadband access for your county and state, as well as our write-ups on the efforts to expand broadband generally, as well as through education, medical, and other initiatives. In particular, the strategy on broadband initiatives for unserved and underserved areas for service also details the costs and benefits of different models of broadband service, including municipally owned and operated networks. And then we also have a webinar that goes into more detail on digital redlining and how to expand broadband equitably. And these are all on our homepage at countyhealthrankings.org. So with that, I'll finish. Thank you so much for having me. I look forward to your questions.
Thank you, Kirsten. That was great. Now we'll have Adam Brzezinski present.
Great. I'm pleased to join everyone else here. I feel like I'm amongst the luminaries of health and broadband. So really humbled to join you. I thought I would just share a few examples of some work that our team has been doing here in Cleveland. Some of you may be familiar with the broadband situation in Cleveland. We have, roughly 50,000 or more households that have no internet of any kind in the city, right? So standing in contrast to a lot of other urban areas in the neighborhood, but maybe some similarities to other, other places in the upper Midwest, sort of Rust Belt cities. The Metro Health where I work, we see about 1 million visits a year amongst over 100,000 patients a year. And just in 2021, we had a commitment to screen 2/3 or more of those patients for social determinants of health, at least once at an outpatient visit. With that screening, we're relatively unique in addition to asking people about transportation, food, housing, intimate partner violence, social stress, social connectedness, and other things that lots of places are asking about in the way of social needs. We're also asking people about their internet connectivity and their level of internet connectivity and their ability to use internet connectivity. And so among the 60,000 or so outpatients that we screened in 2021, one of the things that we found was that more than 35% of our older adults reported having no access to the internet. But one of the more surprising things that we found was that 22% of our patients between the ages of 40 and 64 had no internet access. That doesn't come to us as much of a surprise. We're the largest Medicaid provider in the state of Ohio. But that's the context for the next two slides where I'm going to show you just a little bit of summary data. So could we advance one slide, please? Great. So this is some work that we initiated more than 5 years ago now, where we looked at about 250,000 of our patients, and we examined, you can see in the figure there on the y-axis, we looked at whether our patients use the patient portal, and we geocoded all of our patients by their address. This figure shows them by the zip code. We've done it more fine-grained down to the census block group. But what you see here is a really powerful association between the level of broadband coverage at a zip code and the percentage of our patients who use the patient portal. We're an Epic institution, we use MyChart. So we found this incredibly powerful association. This is one of the things that motivated us to feel that we need to be the type of place that screens our patients for broadband as a social need and refers them to local resources to get them whether they need training, whether they need access, whether they need devices. Next slide, please. We also recognize, though, that use of the portal alone, some folks would be curious about whether it's just sort of use of portal or how closely connected is broadband inequality to some specific high value preventive services and health outcomes. And there are a couple of interesting things from this figure. Note that the x-axis is reversed from the prior figure. So this is the percent in a neighborhood without any type of broadband. This is against the percent in a neighborhood with high blood pressure. This is data just from the state of Ohio, from 2,938 census tracts in the state of Ohio. And the color shading there is a quintile of the area deprivation index, a measure of neighborhood disadvantage, where the light blue dots are the folks, the highest income, most advantaged areas, and the yellow dots are those that are the most disadvantaged. And one of the most interesting things you can see here among this linear relationship is that even within the most disadvantaged neighborhoods in Ohio, there appears to be an association between having broadband and blood pressure control. Oftentimes, I think other data tends to show that relationship across such neighborhoods, and many folks make assumptions that these things track linearly just with income or with neighborhood socioeconomic circumstances. But I think one of the important things that this figure shows is that that trend happens within neighborhoods. I think lending a lot of support to Kirsten's claim about broadband being a super social determinant of health. Next slide, please. Now, this line points the opposite direction, but that's because the thing that we want people to do here is good, as opposed to the thing in the last slide, which is bad. And the thing that we want people to do here is get screened for colon cancer And here what we see is a very, very similar relationship to the prior slide, which is a powerful association between whether people are screened for colon cancer and the percentage of individuals in a neighborhood that do not have any type of broadband. And so you see, just drastically lower rates here. So sort of at the bottom, less than half of folks in the neighborhood up to date on colon cancer screening versus 75% according to broadband penetration. And once again, we see this difference as occurring within the quantiles of neighborhood socioeconomic position, not just across them. So I think those are the fun eye candy results that I think really show, in my view, that broadband is deeply connected both to health outcomes and use of high value preventive health services. And I'd love to hand it on to the next presenter.
Thank you, Adam. That was also impressive. As a researcher myself, and for our audience participants that are researchers, it's the kind of data that really is appealing and makes one wonder about the nature of these relationships and their complexity, and we'll want to perhaps talk a bit more about that. But now I'm going to turn to Patricia Keenan. Patricia?
Thanks, David, and thank you also. There we go. Thank you also to the FCC and Connect to Health Task Force for the opportunity to present and really learn from this terrific panel in today's prior sessions. I'm Patricia Keenan. I'm from the Agency for Healthcare Research and Quality. AHRQ's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. Today, we have a remarkable window of opportunity as well as substantial needs to address social determinants of health, and AHRQ is working to respond through a range of SDOH and equity work underway. I'm going to speak today from the context of one AHRQ initiative, the Social Determinants of Health Database, and not necessarily on behalf of AHRQ or HHS overall. The Social Determinants of Health Database Initiative is working to create a robust, one-stop, community-level data resource drawing from multiple public sources, including, in fact, the county health rankings data, so it's nice to connect via this panel. The goal for the database is to make it easier to use social determinants data and analyses that can inform interventions to reach people in need and ultimately contribute to improved health equity. We're developing the database in stages so we can iteratively incorporate feedback and improve over time. The initial database is available on our website now. It includes county as well as zip code level data on topics ranging from income to air pollution, healthcare access. We're also working currently to update the database and add newer data, and this is anticipated to be available later this spring. So we're very interested to collaborate with folks using the database, both to receive feedback to help us improve it, as well as also to really put the data to work in analyses to inform actions to address social determinants. So the map on the right, which is maybe a little small, it's a screenshot of a data visualization on poverty and internet access that we created from the database. And this was developed in recognition of the factors spoken about previously related to the key role of broadband, as well as computer devices such as having a laptop or a smartphone for multiple aspects of people's well-being. So the map's showing variation across counties in the percent of households with any kind of broadband access, including cell phone data plans, ranging from the lowest percent with the lightest color to the highest in the darkest color. And one takeaway I'll highlight that other folks have mentioned is that lack of broadband and this related issue of not having some kind of computing device is for sure a challenge in rural areas, but also urban areas, and particularly among communities with higher poverty rates. And to me, this points to multiple factors that can impact people's ability to benefit from broadband. There's clearly the infrastructure aspect. In addition, it needs to, be affordable, and there are digital literacy aspects as well. And so thinking about, how we understand these factors in more robust way, we of course need data. So, going from my starting point, working on the SDOH database, this map is using data mentioned previously from the Census Bureau American Community Survey, which is a tremendous resource for being able to calculate community level data on a range of social determinants, including household broadband and device adoption. One factor here is that it does require using the 5-year files to be able to support community level estimates. And one possibility that we're hoping to pursue in future work is small area modeling, working with the Census Bureau to be able to generate single year estimates of the broadband and computer variables at a small geographic area level. Thinking about the health data landscape more broadly, just a few comments from a quick and, with caveats, not systematic look for data related to broadband and computer adoption and use. So one standout among federal health surveys is the Health Information Trends Survey with rich questions. And I think actually our next panelist will discuss this. It's used in several of the Healthy People objectives. In 2 other respects, again, from my not comprehensive, but effort at a search, it seems like broadband and computer use kind of data is fairly limited. Looking across 4 federal surveys that are commonly analyzed for topics like access to care and health status, there's limited information. And Adam just spoke to this, but in clinical settings, my sense is that this is not routinely asked and recorded, just based on looking at some of the patient social risk screeners that are commonly used in healthcare to identify and refer people to social services. With the exception of Metro Health, as Adam was just speaking about. So thinking about research, one overarching question, and this has certainly been noted in prior sessions, is whether the trend toward digital healthcare is creating new kinds of inequities, and perhaps particularly among populations already at risk for greater health needs, seniors, lower income folks, et cetera. So 2 broad kinds of studies where there's already, as we're hearing, great work that's been done, but where it seems like there's also a lot more still to learn that I'll just note are first, intervention studies. For example, what kinds of modalities of telehealth are effective? And particularly thinking about populations with differing levels of digital access and literacy. And, related to that, what kinds of interventions are best done in a clinical setting versus a community setting? And then second, for health services research type studies, a whole range of questions related to how broadband is associated with the use of specific types of digital healthcare, which Adam was, again, just speaking to, as well as related to other aspects of well-being, such as schooling, employment, and then ultimately, from a health policy perspective, what are the impacts on healthcare use and health outcomes? And so last, I'll just note for the research community, it seems like there's a lot of methods opportunities here. And just to note a couple, thinking about observational studies using large data sets, thinking carefully about approaches for causal inference, as well as for how to do multi-level modeling in data where, ideally we might have individual or patient data grouped within healthcare delivery institutions and then across communities. And at the same time, though, considering the need for qualitative research and, to co-design studies so that the work can be informed by people that, these technologies are aiming to reach. And, so that ultimately research questions and interventions fit with people's preferences and circumstances. So I'll stop here and look forward to follow-up discussion. Thanks.
I just wanted to just mention to Patricia, a number of her comments, I think, were spot on to the Q&A and to our questions around multi-level modeling. What are some of the methodological challenges? We'll get a little bit wonky as researchers, and I think that's a good thing. But Robin, please go ahead.
Great. Thank you all so much. Again, I also want to add my thanks to the FCC and the meeting organizers for the invitation to be a part of this important meeting. in this esteemed panel. We are the last session before the end of the day as the meeting wraps up, so I'll try to keep my remarks brief. As this discussion today has been so comprehensive and thought-provoking and inspiring. And first, I want to step back and just frame out why a federal cancer research agency like the National Cancer Institute would be focused on broadband connectivity as a social determinant of health. And it's obvious, again, based on today's symposium and the data and the comments and the experience and lessons learned that have been shared today. Again, it is clear that broadband connectivity is linked to health disparities within and between different population groups. And NCI is firmly committed to supporting research that identifies and addresses health disparities and advances health equity among all communities. And in particular, the branch where I sit at the National Cancer Institute, which is the Cancer Communication and Informatics Research Branch in the Behavioral Research Program, is committed to an area and maybe a different or another frame or a different conceptualization of what we've been talking about today. And our branch is focused on communication inequalities. And, thinking about that, what do I mean by communication inequality? And we often draw from Vishwanath's work at Harvard in that communication inequalities are defined as the differences in the generation, manipulation, and distribution of information among social groups, and the differences in access and use, attention, retention, and capacity to act on relevant information among individuals. And again, I think it's very clear today that underlying these differences and underlying these communication inequalities in the generation and use of information is availability, access, and use of internet and technology, and its related counterpart of health and digital literacy. And so obviously NCI wants to be part of this coordinated and synergistic effort that we've been hearing about all day today to understand and surveil communication inequalities and to support research from our extramural community that addresses and mitigates these communication inequalities. As related to our cancer research portfolio and our priorities at NCI, broadband connectivity actually affects many aspects of our work as well as the work of our grantees. But for the sake of time this afternoon, I'm going to briefly describe two of those initiatives. The first is how we at NCI and in collaboration with our other federal agencies such as Healthy People 2030, as well as our partners at ONC and other agencies, how we monitor the changing communication ecosystem, which we've been hearing that word over and over again today. And that is through our seminal health communication surveillance tool. Patricia just mentioned it for us. It's the Health Information National Trend Survey, or HINTS. And for almost 20 years, and in fact, in 2023, we will celebrate the 20th anniversary of HINTS. We have been measuring such important metrics and variables, such as, do individuals have access to and use the internet? How is it accessed? Is it over cellular service, broadband? And that obviously has changed over the last 20 years, even the different response options that we've had for those metrics. How do you use the information for your healthcare needs? And what is your experience of seeking health and cancer information, in particular when using the internet? We've also had measures that focus on how individuals use health and wellness apps, wearable devices, patient portals, and access their medical records online. And then whether folks are willing to share their patient-generated data with healthcare providers. And if you think about it, all of this, again, is dependent often on internet and cellular and broadband, access to do all of these things that we've been talking about all day today and what we're measuring on HINTS. We're really thrilled that HINTS 6 is actually going to launch this month. And we have a new question that we're adding related to satisfaction with the internet connection at home, which I know has been discussed earlier today. And we are going to have a new section on the HINT survey dedicated explicitly to telehealth. Again, as a result of the pandemic, we are shifting our priorities and metrics that we're looking at across HINT to incorporate telehealth. So again, I would encourage any of our public, private, and federal partners to use this HINT data to further understand and monitor broadband connectivity as a social determinant of health. And again, we're even in our infant stages of working with the FCC to see if we can link FCC broadband data and our HINT data as well. So it's very exciting work. The second area that I'm going to briefly highlight as well is focused on our new growing area of science that is dedicated to telehealth related cancer care. And I think, again, it's been covered explicitly today that the healthcare system turned on a dime to start offering virtual care. And that has happened in primary care, specialty settings, and in oncology care. But it's a little bit been where research is playing catch up to this overnight change in healthcare delivery. And we're in essence building the plane while we're flying it. And we have put out a research agenda where we want to establish how telehealth can be integrated and sustained into existing and new cancer care delivery models. We need to establish the evidence base around, again, how telehealth can complement in-person care, and particularly in a unique situation like cancer care, where you still need to have many of the appointments in person, including testing, treatment, screening, exams. But there are also opportunities for remote symptom monitoring, the hospital at home model that's been talked about earlier today, and also thinking about how we can use telehealth to support recruitment and retention in cancer clinical trials. And I would encourage us to think about this, about delivering the right care on the right platform at the right time and equitably to all patients. And we hear a lot about precision medicine in oncology care, and we can think about this as precision delivery of oncology care. And of course, it never fails when we're presenting this research agenda that we get asked the question is, how is broadband connectivity for both patients and providers going to be addressed? How are we going to manage the unintended consequences and prevent this exacerbation of existing cancer disparities? Again, everything we've discussed already today. And these are real and valid questions for our research and clinical community and our funding agencies. And so again, with one of our recent funding opportunities that's focused on centers of excellence in telehealth and cancer care, one of the research requirements that we wrote into the funding opportunity was that the work needed to be, the research study itself needed to be a pragmatic, randomized controlled trial, meaning that the research study had to be done in a real world clinical practice environment, not artificially derived, no controls on the environment and what was happening. But again, taking place in the real patient, provider, health system, community ecosystem that the patients live and revolve in. And so that was, again, an area of research that I think we can promote, is doing this in with pragmatic trials and in real world clinical settings so that we can see exactly when the red flags start to pop up and how we can help our patients. The other part of this funding opportunity was that applicants had to describe and propose plans to monitor and address, again, in real time with triggers and flags for telehealth related disparities. And similar to what we talked about throughout the day, it's not just a yes or no. It's the availability, the access, the affordability, the quality, the stability, the satisfaction, and the reliability. And there had to be both qualitative and quantitative assessments in real time of the patients and providers' experiences with telehealth. And then last but not least, we also focused on both synchronous, so the real-time patient-provider interactions, such as what we're doing today, but also the complementary asynchronous interactions, which again, we've heard about today with patient portals and sensors and wearables and other patient-generated data that can support this tailoring of telehealth and other healthcare services to our cancer patient populations. Our centers will launch later this spring and will be 5-year initiatives, and we look forward to that announcement. So with that, I'll stop, and I also look forward to the questions that you have this afternoon. Thanks, David.
Thank you, Robin, and thank you to all of our panelists. You did a fabulous job of staying to the time that we had suggested, and it does in fact leave us some time to have a Q&A among us, and then also perhaps to take some questions from the audience as well. So I'm going to actually adopt the approach used by my co-moderator from the last panel, Dr. Blumenthal, and ask each of you whether you have a question for each other. Does anyone want to ask one of your fellow panelists a question first?
I do. I have probably questions I could ask everybody. It's a dangerous question, David. But actually, I was curious if Robin Gilbert could share, that data was awesome to see. And I was wondering, though, if you would dare any 12 or 24-month projections on trends in especially use of video visits for telehealth.
Thank you for that question, Adam. There's been so many interesting topics raised today, and I feel like our ocean of claims, I would love to just bring you all out on our glass bottom boat and let you see what we're seeing and to share with you, because we have so many data gaps that we can fill. And we're particularly excited, as I mentioned, starting January, we now have that modifier that we can look at audio only versus telephonic. But it also harkens back to a panelist earlier who said, I think it was the gentleman from Brigham, from Massachusetts, who said that there are some patients who really don't want to access certain types of technologies. It's not because they don't have access to it. So it'll be fascinating to juxtapose our data and how people are accessing care with whether there is broadband access or with more qualitative analyses, as Patricia mentioned, in terms of what are people interested in doing and how do they want to access it. I think there's also, we're seeing a lot of asynchronous types of technologies that are helping people to manage their chronic conditions. And so we're really interested in looking at, we have de-identified patient cohorts. We can see their migration through the healthcare system, tagged with their diagnoses to see how they're accessing care. Are there differences, whether you are using only audio versus video as well? Are there different diagnoses that lend themselves more to one modality versus another? Is asynchronous really helping with discharge from acute facilities and having people maintain and adhere to certain treatment protocols? I think in terms of trends going forward, there's clearly staying power with respect to mental health conditions, but we're seeing a lot of other diverse conditions emerge in the telehealth space, like developmental disorders, which we had never seen before. We're also seeing things depart from joint and soft tissue diseases. PT is becoming more and more common using a telehealth modality. So we're tracking what's different. I would make reference to our free telehealth tracker that is tracking it month to month. We release it every month on our corporate website. And so I invite you to track it along with us. We look at the specialists who are really providing that type of care, how it's breaking out in terms of regions. And we are obviously going to be monitoring this. And we were monitoring this even before the pandemic started. So we've been part of these like class 5 rapids as the pandemic started in trying to really track these trends. So offline, Adam, if I'm happy to share more with our data and also to help any of you with any of your studies that we can help you peer more closely into specific corners and to see how broadband access impacts outcomes.
Well, I'll say thank you to I'd like to say thank you to Robin as well, because we have used your tracker in many of our early presentations and work in telehealth, because you were literally tracking it and put it on your public website, as you noted, with the bar graphs, and incorporated that into some of our early presentations, because it was the data we could get our hands on and find publicly. So thank you for that. And I too would be interested, as you look at the different diagnoses, among the patients and their their comorbidities potentially as well if there are multiple diagnoses. But and see where oncology sits. But thank you for your all's reporting.
Thank you to both Robins. So with our remaining time, I wanted to just ask the one question, if each of you could respond. What should future research address to examine the relationship between broadband connectivity and health? Where are the gaps? What do you think where should the research go? And so, Kirsten?
Sure, thank you so much. I think the work that I have particularly been involved in would point to more research needed around what service models are most effective at expanding affordable broadband access. So we know from different data, including FCC, that areas with only one provider might be limited in how they can ensure affordability, especially in states that prohibit local broadband subsidies, public-private partnerships, or municipally owned and operated broadband. So getting more granular data about what models are actually working best and where to expand that affordable broadband. And then the last thing I would mention is that what existing infrastructure is already in place in communities that are lacking broadband, because often like communities that are looking to expand it aren't aware of folks that have comparable infrastructure who have built on what already exists. So just getting folks connected to each other would be great.
Wonderful, thank you. Patricia.
The one area that I'm particularly interested in is, a whole range of questions that could be answered, linking individual or patient data with community level data. With broadband access, a number of people have pointed out the importance of both, is broadband offered in the community, but then also the adoption of broadband and computing devices in the household, and finding ways to link data sources so that studies can account for both that sort of individual piece as well as the community piece, to think about, how ultimately people are using modalities such as telehealth and the impact on healthcare use and outcomes. I think, there's a bunch of questions there that I didn't, that could be asked more specifically, but all in that space of thinking about individual and community level data kind of combined in analyses.
Thank you. Robin V.
Yes. So I would argue, I think that looking at the return on investment, the value-based argument, the cost effectiveness of providing internet access and or devices and or related training and technical support to patients, how that again plays out in the impact on health outcomes. So I think we need more economic analysis of this work to help us make the argument in the case.
Thank you. Adam?
This is a tough one there. Everything everybody else said, plus a couple of them. One, I'm really curious whether the surge in access under emergency broadband benefit and affordable connectivity programs translated into increased uptake of preventive health services, increased usage of patient portals, and increased access to primary care providers, especially. That one for sure. And then sort of like on the other side of it, I'm also just continuing to be deeply concerned that ongoing digital divides are creating fast lane and slow lane for access to high value subspecialty care, such that, some of the precision medicine things that Robin was talking about, that folks who do have access to the portal, who do have access to sign up for clinical trials or, sort of enriched access via the internet, have a fast lane to receiving, life-saving subspecialty care that might not be available to folks who don't have that sort of access. So I think that's another really important direction to be looking at and monitoring.
Thank you, Adam. Very important point. And Robin G., last comment in just a moment or two, if you would.
Sure. Just really to help everyone that has spoken today, maybe help them do what they do even better, and to allow us to help everyone, would be the addition of a Z code that reflects in the claim itself the lack of broadband access. We are doing a lot of rich research with respect to social determinants of health involving divorce, death in the family, food scarcity, low literacy. It's allowing us to shed light on the association of those social determinants with health outcomes. Having a broadband access specific determinant of health that's coded as a Z code would greatly propel us forward and allow us to make publicly available information on this topic. So that would be my wish list.
Thank you, Robin. And I realize we're at the end of our time. And I know there may have been questions. I know we've had staff trying to answer questions in the Q&A section. We now need to conclude our panel. I want to thank all of our panelists for a very stimulating discussion, and this will continue. The discussion will continue. I now want to turn it over to our chair, Michelle Ellison, for final comments to conclude our symposium today.
Thanks so much, Dr. Ahern. What an incredible day. It far exceeded even our very high expectations, and that is because of all of you, our audience of nearly 300 actively engaged participants. We salute our terrific moderators, panelists, and speakers for their thoughtful input and creative solutions going forward. I do want to say a very few, and I mean very few words to wrap up the day. First, I want to thank Chairwoman Rosenworcel for her leadership and passion for closing connectivity gaps. I want to thank Commissioner Starks and Commissioner Carr for their inspiring remarks today. And I want to thank all of the commissioners for their unwavering support for the work of the Connect to Health Task Force, for promoting broadband and health, and for leading the way on creating opportunity for all Americans. In so many ways, that is the moral imperative of our time, and they are rising to the challenge. I can't help but think about former acting chairwoman Mignon Clyburn today, who was the engine behind the creation of the task force. I hope that we continue to do her proud. Second, to the amazing staff of the FCC who planned this event, we are all in your debt. A special thank you to Karen Onije, Ben Bartolome, Dr. David Ahern, Dr. Michael Gibbons, Dr. Ariel Mancuso, Angela O, Shannon Hyatt, and Dr. Taylor Martin. And another shout out to our colleagues and strategic partners at MITRE Corporation, especially Dr. Samruthi Thakur, the project lead. Finally, I think the phrase of the day was from Dr. Berwick, who encouraged us to act with courage, and as we all know, to act with dispatch. If the pandemic has taught us anything, there's no time to waste. It's clear from today's dialogue that broadband connectivity as a social determinant of health is a critical framework and one with transformative potential. So we would encourage you to stay engaged, to visit our website, to send us comments and suggestions by email. We hope that as a result of today's dialogue, you're thinking differently about the role of broadband in health. We hope this will infect your vision, research strategies, policies, budgets, funding, business plans, consumer education initiatives, and yes, cross-sector partnerships. We at the FCC stand ready to collaborate with all of you, with telecom providers, health systems, public health agencies, researchers, scientists, philanthropists, and to continue to do our part. So a great big thank you from all of us at the FCC. Have a good evening, everyone. Thanks again.